Already.
Perfect. Hi, my name is Sandra Hanna, and I'm the lead clinical pharmacist with Personalized Prescribing. This is our second forum of its kind, where every month we discuss a different topic related to pharmacogenomics. And today's topic is the interplay between SLC6A4, which is the serotonin transporter, and HTR1A, which is a serotonin receptor gene variants that may lead to failure or success of SSRIs. So without further ado, let's start. Oh, looks like the presentation is backwards. Okay. So brain receptor crosstalk. So as you probably already know, brain receptors crosstalk all the time. The body and the brain have all sorts of negative feedback mechanisms to regulate neurotransmission. And the interactions may be important in drug response depending on the respective variants. In this case, SLC6A4, which is the serotonin transporter, and then the HTR1A, which is the serotonin autoreceptor, which we'll discuss in more detail. The SLC6A4, or the serotonin transporter, is essentially responsible for capturing excess serotonin from the synaptic space and recycling it or bringing it back to the presynapse for repackaging into little vesicles for future transmission. So that's what the serotonin transporter does. The HTR1A, and this receptor exists presynaptically and postsynaptically, but for the purposes of this conversation, we're going to talk about the HTR1A or 5-HT1A presynaptic expression. This autoreceptor is the main regulator of serotonin transmission. So generally, autoreceptors are inhibitory. They work to regulate and slightly inhibit neurotransmission. So this serotonin or HTR1A autoreceptor, it applies the brakes on the source of serotonin transmission in the Raphe nuclei and regulates or slightly inhibits the release of serotonin from its own neuron in the presynapse. So getting into the SLC6A4, which is the gene that codes for the serotonin transporter in more detail, as you likely already know, for every gene in your body, you inherit two possible variants. So the two possible variants for the SLC6A4 are the L allele, which is high expression, and then the variant, which is the S allele, low expression. The S allele is known to have a 50% reduction in expression compared to the L allele. It's also less efficient in terms of binding to its ligand, whether serotonin or an SSRI. So if you have two possible variants, it means you have three potential combinations. You could have the LL, which is double expression of the normal or wild type or good variant. You could have SS, which is the short strand or the low expression, which means 50% reduced expression compared to the LL. Or you could have the SL, which is one normal, which is the L, and then one varied, which is the S, and then the reduction there is only 25% relative to the LL. So those are the three possible combination. LL, high expression, SS, 50% reduction, low expression, and then SL, which is kind of in the middle. Now let's talk about the variants of the serotonin autoreceptor, and then eventually we're going to combine all of those possibilities. So the HTR1A is located presynaptically, and like we said, it regulates the release of serotonin from the neuron. If you have the C allele, you have normal expression of that autoreceptor. The variant allele is the G allele. The G allele is actually known to have a 50% increase in expression presynaptically only compared to the C allele. And again, you have three possible combinations. You could have inherited two CCs, which is great, that's normal. Or you could have had or could have two GGs, which would be 50% increased expression. Or you could have CG, which increases the expression of that autoreceptor in the presynaptic neuron by 25%. Let's talk about serotonin neurotransmission in homeostasis without the administration of a drug and without the presence of depression or chronic stress. So in general, your serotonin transporter would be working to capture any excess serotonin in the synaptic cleft, and your autoreceptor would be responsive to the amount of serotonin in the cleft. If you have excess, it would slightly reduce the release of serotonin from the neuron, and if you have low levels, it would likely allow more serotonin to flow through the neuron. So something really interesting is that arguably you would think that if you have the SS, which is 50% less serotonin transporter, you would have 50% more serotonin in the synapse, but that's actually not the case. So scientists did studies in mice where they knocked out half the transporters in a group of mice and then kept the transporters intact in another group of mice, and then compared the level of serotonin neurotransmission, and it was about the same. So they mimicked the SS in the mice that have half the serotonin transporters, and they seem to have close to the same level of serotonin as those with the LL. They didn't have more. So what they found out was that for those with the SS, the autoreceptor was actually working 36% harder to reduce the release of serotonin from the neuron to keep serotonin levels in homeostasis or at normal levels. So under normal circumstances, the activity of SLC6A4 and HTR1A result in the same amount of serotonin in the synapse, regardless of the variance that you have at the two brain receptors. Now let's talk about chronic stress, which is a completely different situation. So first, let's define what chronic stress is. So chronic stress is essentially just acute stress that is not acute. It doesn't go away. So it repeats itself day by day, month by month, year by year, at which point it becomes chronic. So in acute stress, there's a sudden increase in neurotransmission in the brain to help you cope. But if that continues and is not alleviated, what happens is that your serotonin transporter is upregulated. It's working harder to remove that excess serotonin from the synapse when you're stressed. And your autoreceptor is also eventually upregulated because it's working so hard to chronically reduce serotonin levels in the synapse because you have so much because you're stressed. And when you're stressed in the short term, transmission increases. So over time, both of these, the transporter becomes upregulated. It's working harder to remove serotonin from the synapse, and then the autoreceptor is also more active and it's working harder to reduce the release of serotonin from the neuron to keep your serotonin levels at regular or appropriate levels. So if you have, for example, the G variant, GG, which is the really high or 50% increased expression of the autoreceptor, and you're chronically stressed, you already at baseline have 50% more autoreceptor, and now all of that excess autoreceptor is also overactivated. So you have a lot less serotonin being released from the neuron. So that's what happens in chronic stress. The SLC6A4 and HTR1A are overactivated, resulting in increased reuptake from the synapse and reduced release of serotonin from the presynaptic neuron, and basally lower serotonin levels, which generally leads to depression. So let's talk about SSRIs under normal circumstances. So what they do is that they block serotonin transporters. So the transporter is the drug target. So SSRIs aim to occupy around 70 to 90% of serotonin transporters. Once those transporters are blocked or occupied, obviously there's less serotonin going back into presynaptic vesicles and more serotonin available in the cleft. But as we know, SSRIs don't work right away. They can take up to 8 to 12 weeks to be fully effective. And most scientists agree that that's because it takes time for the serotonin autoreceptor to be desensitized or downregulated. So as soon as you administer the SSRI, you block those transporters. You have this increased level of serotonin in the synapse, but then your autoreceptor compensates for that by releasing less serotonin from the neuron, which is why you don't feel good right away. You can actually feel worse before feeling better. However, over time, you continue to administer the SSRI, you continue to occupy those serotonin transporters. The autoreceptor continues to try to work really hard to keep things at bay and put the brakes on the amount of serotonin being released from the neuron. But eventually, if you keep putting pressure on a brake for a prolonged period of time, say 6 to 8 weeks, the brake shoe wears out. And you've desensitized or downregulated actually that autoreceptor. And now you're able to maintain the increases in serotonin as a result of blocking those serotonin transporters, and you start to feel better, and the SSRI is therapeutically successful. So that's under ideal circumstances. But as we know, the rate of failure for SSRIs is close to 50%, and so circumstances tend to be far from ideal. So let's talk about SSRI failure, and this is where the genetic variants come in. Let's just say you have the SS allele of the serotonin transporter. So you're starting with 50% less serotonin transporters relative to someone with LL. You get on the right maintenance dose, you successfully occupy the required percentage or number of transporters. You block them, and there's a little bit more serotonin in the synapse, but logically, if you have a lesser number of transporters, the increase of serotonin you're going to get is more subtle relative to someone with LL because there's simply less to block. So you've blocked everything that you can block. You've increased that serotonin transmission in the synapse, but then assume you have the GG autoreceptor. So you have a very highly expressed autoreceptor that generally reduces the release of serotonin from the neuron. Your postsynaptic receptors are cross-talking with your autoreceptor, telling it there's a little more serotonin in the synapse. They're communicating with the autoreceptor to now release less serotonin from the neuron. So that's happening, but you have so much autoreceptor that subtle increase in serotonin and that continued administration is simply not enough to overcome the autoreceptor, to desensitize or to put the brakes or to downregulate the autoreceptor. So overall, the increase in serotonin is subtle and the SSRI just doesn't work. So these are all hypotheses that different scientists have come up with. They did different mouse studies. They studied the serotonin transporter on its own, and they found that those with the SS allele had a higher side effect incidence in general. For the most part, didn't respond as well. And they also studied the HTR1A serotonin autoreceptor and found that those with the G allele didn't respond very well to SSRIs, but studies were conflicting, and there's very few studies that looked at the SLC6A4 serotonin transporter in combination with the HTR1A autoreceptor. So what we did was a retrospective data analysis. We downloaded all of the data from about a total of 492 patients, and we actually eliminated anyone that was below the age of 18, anyone with any diagnosis that wasn't just depression and or anxiety. And then we also removed anyone that had a metabolic problem with their CYP450 liver enzymes. So a CYP2C19 ultra rapid metabolizer or poor metabolizer or CYP2D6 poor metabolizer. All of those people were eliminated so that if a person did fail for metabolic reasons, our results wouldn't assume them to be failing because of their brain receptor variants SLC6A4 or HTR1A. We ended up with a cohort after eliminating all these people of about 459 people. So out of the 492 people, we'd already eliminated anyone that didn't meet our inclusion criteria. And then we eliminated 33 people exactly that had both a CYP2C19 and a CYP2D6 problem. We ended up with 459. Our hypothesis, according to everything that we've read and everything we've observed with how our patients respond to drugs, is that patients with the L allele of SLC6A4 and the C allele of HTR1A would be underrepresented because those should be the good responders. Anecdotally, we didn't see them frequently. And all of the studies corroborate that information. And then we hypothesized that patients with the S allele of SLC6A4 and the G allele of HTR1A to be overrepresented in our population. So just for context, let's look at how these two genes present individually in the general population within all ethnicities. So for the SLC6A4, around 25% of human beings are LL, around 50%, half of human beings are SL, and then SS is around 25% of the population. For HTR1A, for CC, which is the good variant, that's 27.13%. For CG, that's 49.9, close to 50%. And then for GG, that's 22.96 or 23% of the population. And then we multiplied them by each other to see how they present in combination with one another. So as you can see, the LLCC, which is ideal, it presents only in about 6.8% of people. And then the SSGG, which we hypothesize is the worst combination, only presents in about 5.74% of the general population. And then the most common combination is actually SLCG, which is still a good combination, and that's close to 25% of the population. Now, we don't have to spend too much time on these numbers because we'll come back to them. Okay, so these were our findings. So remember how I said that the LLCC, sorry, was the best possible combination. In our population, it presented in 22 out of 459 people, or 4.8% of our cohort. In the general population, including all ethnicities, Caucasians, Asians, everything, it was 6.78%. So in our population, the LLCC, which is arguably the best combination, was underrepresented by around 30%. And then the SSGG, which we hypothesized was the worst combination, was overrepresented in our population by 93.6%. So you see 51 out of 459 people. If you look at the very last row, SSGG, 11.11% of our population, and only 5.74% of the general population. So literally close to 100% more, or double. So that's striking. And interestingly, of these 492 people, around 302 of them are disability patients. So close to 60% are people who were referred to us as a result of disability and have definitively failed one medication. So we know that for a fact. And we're seeing an overrepresentation of SS and GG by close to 100%. If you're interested, we can send you a copy of the slide to look at in more detail, but you can see progressively SLCG, which we said is the majority of the population, close to 25%, and is still amenable because you have one L and one C. It's only 15% of our population relative to 25% of all people. SLCC, also overrepresented by 30%. LLCC, underrepresented, also underrepresented by 30%. And then you see that wherever there's a homozygous G, a double G, you have an overrepresentation. So SLGG, overrepresented by 11.99%. LLGG, overrepresented by 25%, and SSGG, of course, overrepresented by 93.6. And the same is true if you look at the SS individually. SSCC is overrepresented by 18.85%. And then you see SSGG is overrepresented by 27.45%. And then you have SSGG, which is the worst combination of all, an overrepresentation by 93.6%. So these numbers follow a sequence. Again, note that the very worst overrepresentation was for the SS and GG cluster, validating our earlier discussion. And like I showed you, note that the patients that have either the SS or GG individually, not necessarily in combination with one another, or in combination with one another, are all overrepresented. And if you go back and you tally those up, the sum of the overrepresented cohort is about 50%, which is very similar to the reported failure for SSRIs. And you could literally go back and you could see SSGG in our population, 11.11%. And then you could do SSGC. At that point, you're already at 25%, and LLGG, 7, and so on. It tallies up to about 50%. So obviously, the reason for SSRI failure can be largely explained by genetics. The pharmacokinetics is simply not sufficient to explain the failure of SSRIs. So remember, I told you all that we eliminated those that were both had a serious CYP2C19 problem and CYP2D6 problem. 33 people out of the original 492. That's only about 7% of the total cohort. So only 7% of people will fail due to metabolic reasons, which means that the PGX tests that are mainly CYP2D6 and CYP2C19 testing are not useful. They're not sufficient to determine whether an individual will successfully respond to an SSRI or not. A pharmacogenomic test, and of course, personalized prescribing does that, at minimum has to address or test for the SLC6A4 and also the HTR1A autoreceptor. That's a must for patients who have failed their first trial of an SSRI. And that's everything I have to share today. And I wanted to give you a chance to ask questions if you have any. So we got one question. What medication should be prescribed if someone has a combination of SS and GG? So that's a great question. There's multiple medications that can actually address the autoreceptor problem. So someone with an individual SS individually is still problematic, but it's not as problematic as the autoreceptor. So there's two new drugs that have been on the market for multiple years now, vortioxetine and vilazodone. They're HTR1A partial agonists at the presynapse, in addition to occupying and blocking serotonin transporters. So they're dual action in that way, and they work directly to desensitize or downregulate the HTR1A autoreceptor. Whereas with regular SSRIs, it's an indirect effect. It's an effect of increasing the serotonin in the synapse as a result of occupying the transporters, and then that putting pressure on the HTR1A. But vilazodone and vortioxetine, vilazodone is brand name Vibrid, and vortioxetine is Trintellix, put direct pressure on the HTR1A and are a great solution for those that have the SS and the GG. Vilazodone, if you have a CYP problem, is also cleared by the kidneys, and then vortioxetine, which is Trintellix, is cleared by CYP2D6. There's a couple of more questions coming in. I'm just going to go to the chat. One more thing I wanted to mention about SS and GG is that if you have a patient that's already taking an SSRI and they're kind of tolerating it, but it's not working, you can also add aripiprazole. So aripiprazole, which is Abilify, very common adjunct for treatment-resistant depression. It's right in the guidelines if your SSRI doesn't work. At simple doses of 2 to 5 milligrams, Abilify actually has very high affinity and strong partial agonist activity at HTR1A and can also desensitize it and help to enhance serotonin levels and serotonin transmission. We have another question. Does the SLC6A4 gene or HTR1A gene play a bigger role in SSRI treatment failure? So I touched on this briefly. If you actually tally up the overrepresentation, GG is actually individually more overrepresented than SS and is more harmful to SSRI response. So the SS allele plays a bigger role in increasing side effect risk, but on its own, it doesn't cause failure, but it's only with the GG where the drug truly fails, but a GG on its own can cause drug failure, as represented by our numbers. Another question, in slide 12, you indicate that the SS is 25%, but I have read that Asians have a much higher SS population. How do you deal with Asians? So it's interesting that you mentioned that. Yes, SS in Asians does seem to be overrepresented. However, the MAO gene, and this is a bit of me going on a bit of a tangent, but in Asians, the MAO gene, which actually is responsible for breaking down serotonin, Asians tend to have a highly active MAO, so they tend to, if depressed, become at risk of basally lower serotonin and still respond to an SSRI despite having the SS. And it's not just the L or the S. So there's also an LA and an LG. So LA presents as a true L, and then LG presents like an S. And although Caucasians have a lot of LG, Asians actually have less of it. So factoring that in, Asians actually have this approximately the same expression of SS, or 50% reduction in serotonin transporters, as do Caucasians. So that was kind of a confusing answer, but if you are interested in a reference, I'm happy to send you one. But overall, Caucasians and Asians have approximately the same incidence of SS, because at the time that these studies were conducted, they didn't account for that discrepancy where there is an LA that actually presents as a true L and then an LG that presents as an S. Caucasians have more of the LG and Asians have less. And so overall, with all of that factored in, Asians and Caucasians present very similarly for serotonin transporter statistics. Is buspirone an option to augment with SSRIs for patients with a high HTR1A variant? Absolutely. So buspirone is also an antagonist at HTR1A. The only drawback of using buspirone is that it's dosed 3 times daily, which can make it a lot more inconvenient relative to a drug like Abilify, or just administering monotherapy of vilazodone or Vibrid, and then vortioxetine, which is Trintellix. And buspirone is also not selective, so it's not selective for the pre or post synapse, so people have mixed response to buspirone. What is the role of metabolism in drug failure, the rate percentage of drug failure due solely to metabolic issues? So as we mentioned, only close to 7% of people will actually have a problem at both CYP2C19 and CYP2D6. So CYP2C19 is responsible for breaking down and clearing sertraline, which is Zoloft, and then citalopram, which is Celexa, and then escitalopram, which is Cipralex, and then CYP2D6 clears nearly all of the other antidepressants. And having a problem in both accounts for only 7% of the population. And there's also a couple of antidepressants that are cleared by the kidneys. So desvenlafaxine, which is Pristiq, vilazodone, we mentioned that, which is Vibrid, and then levomilnacipran, which is Fetsima. They're all cleared by the kidneys. What is the role of metabolism? There are many PGX tests in the market, but not all of them are effective. What is the reason? So like we mentioned, there's certain criteria that will determine if a pharmacogenomic test will be effective or not. So the first thing it should address is metabolism, so CYP2C19 and CYP2D6. And most tests already do that, but that's not enough. Just because you have the right levels of something in your body, or just because the dose can be adjusted for safety, it doesn't mean it's going to work. The second thing that the test has to address is the blood-brain barrier. So SSRIs in general tend to have a high affinity for the PGP pump, which is P-glycoprotein. P-glycoprotein is a pump that expels anything from the brain that the brain recognizes as a foreign substance. SSRIs have a high affinity for PGP and a high propensity for being expelled. Different SSRIs have different affinities, and depending on your activity of PGP or activity at the level of the blood-brain barrier, you may be more prone to expulsion out of the brain and into the bloodstream, which can cause side effects, or you may not have a problem at all. So that's step number 2. Step number 1 was the metabolic. Step number 2 is the blood-brain barrier to see if antidepressants can effectively cross into the brain in a sufficient enough concentration to be effective. And then step number 3 is the pharmacodynamics. So the different brain receptors that play a role in response, the target, like the SLC6A4, the indirect target, like the HTR1A, and then some of the postsynaptic receptors, like the HTR2A, 2C. All of those can either help response or interfere with response. So the full downstream effect of the drug has to be accounted for. So 1, pharmacokinetics, 2, blood-brain barrier, and then 3, pharmacodynamics. And ideally, that information should be condensed in a 1 or 2-page summary report with a clear, concise recommendation for the doctor by a licensed registered pharmacist, 1 or 2 paragraphs of rationale, and then maybe a small list of likelihoods of response to different drugs. The patient should be properly counseled on that medication by their pharmacist. The summary report should be shared with the physician, and pharmacists should be available to follow up with patients as needed because their treating physician is likely very busy. Are you saying that you can help all my patients regardless of their metabolic or brain receptor variants? So we can help a large majority of your patients. However, there are people that are treatment resistant, and we can identify that, and we can tell you that they're treatment resistant, and we can refer them to alternative therapies like ketamine, psychotherapy, a combination of both, um, possibly transcranial magnetic stimulation. There's no such thing as perfection, but we are able to at least identify the problem. Do you have any thoughts as to why a small amount of theoretically good responders based on their SLC6A4 and HTR1A genes still failed an SSRI in your study? So that's a really important question. So for the purposes of this presentation, we only had time to discuss the SLC6A4, which is the serotonin transporter, and then the HTR1A, which is the autoreceptor, but there's all sorts of things that play into successful or unsuccessful SSRI response. So, for example, there are a lot of people with, there's another gene, it's called COMT. It stands for catecholamine methyltransferase. What this COMT gene or enzyme does is that it actually breaks down dopamine in the brain, and it breaks down adrenaline in the brain, mainly in the prefrontal cortex. And people with certain variants have higher levels of degradation or getting rid of those 2 neurotransmitters. And multiple meta-analytic studies show that people with the high breakdown variants for COMT, which is COMT-GG, respond better to a drug like Wellbutrin, implying that they may not have a serotonin problem. They may have a dopamine problem. They may have an adrenaline problem. They may have high expression of a serotonin receptor downstream called HTR2C. When activated, that receptor actually increases the activity of the HPA axis and cortisol, and possibly inflammatory cytokines. So it's not just those 2 genes, and it's not just those 2 genes that we test. Our algorithms are very, very comprehensive. And so there's other genes that can interfere or impede with response that weren't discussed, which is why some of these theoretically good responders that have, say, LL or CC may still have failed. Am I saying that genetic variants of HTR2A and HTR2C can cause SSRI failure? Yeah, in some cases they can, definitely. And there are drugs, for example, fluoxetine, which is Prozac. It not only is an SSRI, but it's also an antagonist at HTR2C, which would be an ideal solution for those with high expression of the 2C receptor. Thank you. So that looks like that's all the questions we have for today. If you have any other questions or concerns, feel free to send me an email at sandra@personalizedprescribing.com or info@personalizedprescribing.com. I'm happy to share any of these references with you or continue this discussion. Have a great evening. Bye.